Hi, everybody. We are glad you could join us today for the ECG webcast, Key Steps to Successfully Negotiate Payer Contracts. My name is Dan Cosentino. I'm a manager at ECG, and I'm pleased to be your moderator for today's program. Today's presentation and discussion by ECG's ASC team will focus on the types of services that pose opportunities for ASCs, as well as ways to optimize payer contracting outcomes at a time when the environment is rapidly changing. Attendees will learn about trends in case migration, payer reimbursement, regulatory implications, and strategic and financial considerations that continue to influence ASCs. Additionally, we will review the importance of understanding how cases are reimbursed and the unique aspects of each payer's reimbursement systems. We will also provide information on different approaches to negotiation and effective strategies for working with payers to ensure adequate reimbursement for new services. Before we begin the formal program, let's go over a few details about the webinar. Today's program will be 60 minutes in length, which will include 45 minutes of presentation and 10 minutes for questions and answers. Everyone should have received a copy of the session handout, but if you are a late registrant, you can download the handout in the handout pane on your screen. Attendees are participating in listen-only mode, but if you have questions, you can type them into the questions pane on your screen at any time, and we will address them at the end of the formal presentation. If we are unable to answer all the questions today, we will follow up with you after the session. And finally, upon exiting today's program, you will be directed to an electronic survey. Your feedback is important to us, so please take a minute to complete this survey. For each completed survey, ECG will make a $5 donation to Doctors Without Borders. Now, joining me today is Naya Kihayes, a principal and ambulatory surgery practice leader at ECG. Naya is an ASC industry leader with over 25 years of experience dedicated to optimizing the business of ASCs as a result of deep expertise in the economics of the business, payer reimbursement methodologies, and contracting. Also, we have Matt Kilton, an associate principal that leads the managed care contracting division of ECG's ambulatory surgery practice. Matt has over 25 years of experience, including 18 years of managed care contracting on behalf of ASCs, physicians, and ancillary providers. Amy Coletti is an associate principal in the ECG ambulatory surgery practice. Amy has over 25 years of experience representing both payers and providers, including ASCs, physician groups, and hospitals in managed care contract negotiations. Kevin Dowdy is a senior manager in the ambulatory surgery practice. Kevin has spent over 20 years working among the foundational departments of healthcare provider organizations, which is demonstrated through his deep understanding of provider contracting and its impact on the broader enterprise. So now we have our agenda. I'll cover the learning objectives. Matt will cover key stakeholders in surgery migration, followed by Amy, who will talk about the payer environment, and Kevin will wrap things up with the key steps to contracting success section. So our learning objectives for this webinar, we're going to evaluate trends in migration motivated by changing rules of payer policies. We will assess the opportunities for ASCs in alignment with hospitals and implications on managed care contracting. We will review payer trends and insights. And finally, we'll outline key steps to optimizing negotiations to prepare for new services. And that being said, I will go ahead and turn things over to Matt.
Thanks, Dan. I'm going to start on slide 7, and this is really the historical background or context behind these managed care contracting conversations that we're going to focus on. We're seeing and have for some time a continued driver of surgery migration, and the drivers are listed on this slide. That's sort of the top row, the employer and payer on the left and right, and then patient in the middle, all basically have the same interest, and that is cost savings and access to reduced overall cost for their services. Employers, because obviously they're paying for the premiums or self-funded programs. Payers are in that similar position where they're funding a lot of these services through fully insured products or managing even Medicare products. And of course, the patient, who ultimately is seeing an out-of-pocket exposure and an increasing out-of-pocket exposure. And some of that is then driving, on the patient's behalf, pricing transparency or the need to understand what these services are costing. In that middle row, the physician and ASC leadership group, they also share a common vision or desire for case migration, but it's not always cost-driven. For physicians, it's efficiency. There's an opportunity potentially for equity or ownership in an outpatient surgical facility. and potentially access to alternative payment methodologies, cost savings programs, things of that nature. On the ASC leadership side, the goals include increasing access to case volume, opportunities for enhanced performance financially and otherwise, and then obviously growing and sustaining a profitable venture, and in some cases alignment with health systems. And then at the bottom row, hospitals, we're seeing a slower adoption of migration from the hospital world, but it is gaining gaining in speed and intensity. And hospitals are now under significant pressure to offer alternative cost settings. We're seeing a lot of pressure under the transparency objectives and goals, and hospitals are also being approached by payers for alternative payment methodologies, again, cost savings programs, and historically haven't been well positioned to function in those environments. And lastly, CMS, and not to say CMS is the last in terms of migration, but CMS and its methodology selections has had an impact on migration, and especially in the last few years, and we'll get into that in some subsequent slides, how that acceptance or allowance of new services has enabled a broader shift in migration in cases. We've seen commercial payers have a little more of an aggressive stance towards case migration, and we're seeing Medicare over the last few years following in an allowance. And of course, the COVID-19 experience that we're all going through has accelerated migration out of hospitals and into surgery centers for a variety of reasons. The ability to service cases in ASCs has been there, but hasn't necessarily been adopted for a number of the higher acuity services. And as hospitals become more focused on caring for COVID related issues, there's been a lack of opportunity for urgent and emergent cases to be performed in those traditional hospital settings, and those have migrated into ASCs. We've even seen payers take a more aggressive stance towards allowing some of those services in ASCs in situations where historically they may not have agreed to reimbursements. I'm going to move on then to our next slide, slide 8, and think a little bit around the concept of, or speak a little bit around the concept of migration trends. And this is not a new trend, right? We've seen for years and years different services that were historically on the inpatient side move into a hospital outpatient department setting, and then convert over to or move to an ASC setting. And there are a number of drivers. On the far right side of the slide, you see those listed. The really needed the clinical capabilities to lead this. We needed to know that those services were safely and effectively performed, and that continues to happen with smaller incision types of approaches, improved pain control and pain management, reduced blood loss, things of that nature. Once it was clinically possible, then we needed Medicare and commercial payers to recognize the ability and find a way to reasonably pay for those services. And of course, physician motivation. There has to be a desire on behalf of surgeons to take the risk, frankly, to move those cases into new settings from historical settings. And so all of those variables or drivers are enabling an ongoing case migration shift. We've listed in the middle of this slide some of the higher acuity services, and not to hit on each of these, but it crosses a variety of subspecialties, orthopedic, spine, ENT, general surgery, gynecology, cardiology. And again, we see ongoing opportunities to capture cases as ASCs have accelerated, or the rule changes have accelerated, and COVID has returned a focus to providing these services in alternative settings that are not hospital-based. Moving on to slide 9, the CMS regulatory considerations are worth visiting. CMS over the past several years has had an enhanced focus on allowing reimbursement and therefore allowing cases to shift. And just taking a few years of the timeline to talk through, the device intensive code list for years was essentially a list of services that had a very high percentage of the overall procedural cost devoted to a device. And in 2019, we saw that that percentage, that offset reduced from 40% to 30%. And that started to capture services like ACLs and total joints and some of the spine procedures. And CMS also in 2019 changed the definition of surgery, which essentially, in their wording, opened the door to cardiac services as well, being performed in a surgical setting. In 2020, the TKA, the total knee arthroplasty, was added, and we saw additional cardiac procedures added to the ambulatory surgery center covered procedure list. We also saw hospital-based procedures approved in the surgery setting, things like the prostatectomy and other high cost or high dollar urological procedures, hysterectomies, mastectomies, things of that nature. And then in 2021, Medicare added the total hip arthroplasty, the shoulder hemi arthroplasty to the ASC list. And so again, just a continued movement or migration from Medicare's perspective. However, looking into the crystal ball a little bit, in the proposed 2022 CMS ASC list actually is unfortunately potentially reversing some of these advances or gains. Currently, there are about 258 procedures that are proposed to move from the ASC list back to the HOPD list, and 298 procedures that are proposed to move to the inpatient only list. And not to get into the specifics of that, but there are services like hemi shoulder. There are some hysterectomy or GYN services. There's some spine services on that list. So again, this is a proposed list. This is not final, but encourage participants of this call to pay close attention if you're performing those services today, because if those services do indeed shift and you have any commercial contracts that are driven by a Medicare reimbursement methodology, so a percentage of Medicare, those services are approved and covered today under that commercial agreement, and they may not be covered under a 2022 Medicare methodology. So important to keep an eye on the list, and also if you see that change happening, reach out to your payer representatives to discuss, is there a way to maintain services in your facility? Moving to slide 10, just an example, the total knee migration, how CMS's reimbursement is influencing the shift or the migration of services. On the left side of this graph, you see the Medicare inpatient allowable for DRG 470, which is total knee. The middle three bars are the HOPD allowable for that same procedure, and then on the right side, the final two bars are the ASC allowable. So what this table is showing us is that the inpatient allowable for the total knee has been relatively flat over the 3-year period shown from 2019 through 21. However, the HOPD rate has grown significantly. And in 2021, the HOPD rate was actually just a little bit higher than the inpatient rate. So signaling to us Medicare's desire to influence financially the goal to shift these cases from an inpatient setting. And then on the ASC side, however, you see kind of a de minimis growth to the 2021 rate from 2020. So not as significant. I think the 21 outpatient rate was about a 3.5% bump. The 21 ASC rate was about 1.5%. So unfortunately mirroring a little bit the way that ASC rates are priced overall. But really, as we see it, the largest limiting factor to case migration from the HOPD to the ASC, especially in this example, is just the cost of the implant. I mean, the cost of that implant doesn't change from those two settings. It's essentially the same, but the reimbursement is remarkably different. And we think Medicare is going to continue to put in place these types of reimbursement incentives or enhancements that allow these migration shifts to continue. Moving then to slide 11 and thinking through what are the things that a facility, an ambulatory surgery center needs to assess to determine its opportunity to perform some of these services. Now there are a variety of issues, but let's focus on the economic considerations. Obviously, case volume and the amount of services that a potential surgery center can perform will be paramount to understanding the economic success. You know, we're talking about 5 cases a year or 500. And then what are the costs to perform those cases should they come over? Drugs, medical supplies, implants, other expenses that are required for the case, clinical staffing, those kinds of things. In addition, capital requirements. Is there any equipment that needs to be obtained? New instruments, tables, radiographic equipment, whatever. And then lastly, what is the market for those services externally? In other words, what does it cost the insurance world, payers, and/or Medicare to receive those services today in the existing setting? And that information is available through a variety of public sources. It's also available through patient EOBs, so explanation of benefits that reflect what those organizations are being paid today. And then lastly, once you have that information, sort of a cost side as well as a market comparison side, an organization can establish a rate target. And that rate target, frankly, should represent a savings. It wouldn't be logical or economically viable for a payer to pay more than they're currently paying for those services in a hospital setting. So those rate targets should focus on opportunity for savings from a health plan and patient perspective. Let's look then at what are the hospital considerations on slide 12 and what are the implications for surgery migration. And I said earlier, hospitals have been a little bit behind in terms of their adoption and focus on ambulatory surgery delivery models, and for obvious reasons. They already have an inpatient setting and many of them have an outpatient deliverable as well. As cost pressures and as pricing sensitivity has increased, that we're seeing an increased focus by our health system clients on an ASC strategy and starting to migrate their cases into that lower cost setting. And there's a variety of reasons listed on this. The risk of cannibalization, the risk of someone else moving those cases through a private investment, private surgery center, a competing surgery center. There's hospitals that are struggling with capacity issues. They don't have enough room. Case demands are growing, so ASCs represent a logical opportunity to move cases to a lower cost setting while still remaining within the system. Some health systems are looking at ASC strategies from a geographic perspective. Can they expand into new markets without the sort of capital investment that a health system or that a hospital might require? And ASC is obviously a much less expensive way to expand the geographic footprint of a health system. Physician alignment, sometimes referred to as stickiness, keeping aligned with your medical staff and keeping that medical staff aligned with the health systems. ASCs represent a very logical means to do that. That third row, payment methodologies that are different than current structures, alternative methodologies, as well as pricing transparency, really driving health systems to revisit this issue. There was a recent article in the New York Times that started to speak to cost variances for the same services in different geographies, and it was remarkable. And that's the information that's getting out to consumers, and consumers are starting to become much more aware of what their services cost. And then lastly, referral networks and payer benefit design as payers implement strategies and processes to challenge or make it more difficult to bring lower cost services. We're seeing health systems revisiting their ambulatory surgery delivery model. One of the simplest examples of that is getting a pre-authorization for a service that can be done safely, effectively in a surgery center, or has been for years, like cataracts or pain management, things of that nature. As payers make it more difficult, it becomes more logical for health systems to offer that ambulatory surgery alternative to their traditional hospital outpatient department. So I'm going to pass the microphone over to Naya, and I think she's going to lead us through some questions.
Great, thank you so much, Matt. So when we're thinking about migration, there's some very key questions that ASC should consider before embarking upon a new service. And I am going to ask a couple of questions to our panel here, and I'm going to start with Kevin. Kevin, for purposes of looking at identifying opportunities, how would you advise ASCs to go about identifying cases to present that present with opportunity for migration?
Thanks, Naya. I think there's several factors to include in that decision-making process to identify cases for migration. But I'd focus on just 3, which would be, start with identify cases through a conversation that you have with your physicians to understand the cases they're currently performing at the hospital. And from there, take a look at those cases and identify which of those are clinically appropriate for the ASC setting. As we all know, we would like to perform more in the ASC setting, but there's some clinical limitations, and those need to be certainly taken into account. And then the last piece, which we'll certainly dig in a little bit later, is look at case costing. Preliminary case costing to help understand the cases that can be performed in the ASC on a financial perspective will be critical to ultimately help identify those cases that can present an opportunity for migration.
Thank you, Kevin. Now I'm going to turn it over to Matt, and I wanted to just preface this with, Matt, you talked a lot about the Medicare rules and regulations and how that list is changing and constantly evolving. And if an ASC has identified cases that they want to move, can they perform them with all payers? And can you talk a little bit more about that process with respect to commercial payers and seeking approval for new cases?
Yeah, it's really the question is should they perform them with all payers? That in most cases the answer is they can from a capability perspective, but we want surgery centers to focus on the should they, and the should is really driven by the reimbursement with the different payers that they're contracted with. If they are a contracted center, each of the payers in these various markets are going to have different methodologies, and it may be one is a percent of Medicare, another is a payer grouper, and it's incumbent upon the ASC to confirm that their contract and the reimbursable amounts for those cases are in fact adequate enough to cover the costs and hopefully return a margin of profit of some kind. So oftentimes the answer is it depends, and it depends on the payer methodology for those contracts that the facility's contracted with. And in addition to Medicare, and we touched on it a little bit earlier, if Medicare's moving services in and out of those approved lists, it's important to stay up to date on what's on those lists.
Yeah, and I'll just add one thing to that. I think what I know I've seen, I know you have too, Matt, is the payers have their own lists, right? And they're constantly moving them as well, just like Medicare. So I think it's important for ASCs to be in tune for that and ask for those lists, because they don't necessarily attach them to your contract, right? So anyway, once you've decided to move these cases and you've identified some of these cases that you want to perform, Kevin, can you provide some thought on what operational considerations an ASC should make?
Certainly, Naya, and Matt touched on this briefly in a previous slide, but the center needs to consider, I think, first and foremost, their equipment to make sure they have equipment needed to perform the new procedures. Capital expenditures can be very costly, especially for new instruments or tables, as Matt mentioned previously. And understanding the return on investment will be critical to know to help with that decision-making process. And I mentioned it just briefly before, but I want to kind of circle back on that. And that's the clinical aspect. Not only just the clinical aspect of what you can perform, but think more broadly with respect to the impact of the new cases would have on the center, be it staffing model, be it number of ORs that you have available to provide the services, et cetera, when you're thinking of operational considerations for those new cases.
Thank you so much, Kevin. And so, Matt, the physicians are the ones that are going to move the cases. So what are some of the key questions the ASC leadership should be asking to the physicians?
Yeah, we want to start with understanding volume, and we want that volume identified by both commercial and Medicare. If a physician has a significant volume of cases, but they tend to lean towards one of those two populations, we want to understand that. And then, of course, confirm with our reimbursements that that's going to make sense to perform. In addition, I want to know what the physician's long-term plans are. Is that individual going to be around a while? Is that individual in the sunset of their career? We want to make sure that if we're going to go down the path of investing in those new services, that there's a long-term play involved, not a short-term. And if that individual is in the sunset, is there a junior partner or a replacement who's coming in to take over that business that will also be able to bring services? And obviously, we want to understand the cost side, and we've touched on this a little bit, but what are the supplies, what equipment, what implants? Are there any special clinical needs? Are there any special outside needs that we need to be mindful of that perhaps are not currently part of the facility's offerings that would need to be enhanced or brought in to deliver that? Things like overnight services. Are there any other elements that we need to be mindful of? And a lot of that is readily available through a conversation with the surgeon and understanding kind of their future goals. And one I noted as I was thinking through this that I hadn't talked to before was just, we want to make sure the physician's contracted with the same payers that the facility is, right? So if the physician is out of network with certain payers, that the facility is in network, or vice versa, it's important to understand that, because that obviously could influence the ability to refer some of those cases into the facility.
Great, thank you so much, Matt. And then I'll just want to close this out and ask Kevin, how is the landscape changing for ASCs, and how the implications of hospital joint ventures have on surgery migration?
Naya, I think that's a great question, because an ASC with a hospital joint venture partner is certainly going to experience migration differently than an independent ASC would. The typical market factors associated with competition with the hospital, those may be completely removed. The hospital may have capacity issues in the operating rooms, and so the ASC presents an opportunity for the hospital to be more collaboratively, to work more collaboratively. And I would just say, just generally speaking, the ASC and the JV hospital should just look at migration as a strategic opportunity benefiting both parties, not just the ASC.
Great, thank you so much. And now we will move on to slide 14, and I'm going to turn it back over to Amy, who will go over the payer environment.
Thank you, Naya. As we've been talking about, there are a lot of changes going on in the environment, and the payer environment in the US is constantly changing and very complex, and will definitely impact your negotiations. In reality, no two payers pay the same way. They may try to tell you that, but they don't. And it's important to understand they each have their own methodology and don't necessarily follow Medicare. I know Matt was touching on some of the methodology. Some payers may actually follow Medicare, but many do not. They may alter it a little bit with multiple procedure methodology changes, or perhaps they'll lock in on a prior year of Medicare, or instead of using your local Medicare rates, use national Medicare. So it's important to understand each contract when you're negotiating, and to understand how you're going to get paid on that contract. And then the other important note, it's interesting, payers can also change methodology without renegotiating the contract. And I know this just doesn't seem right that they can do it, but they may update their, if they're on a grouper methodology, many payers have their own proprietary groupers. So they may send a notice quarterly or annually, and whether it's a notice or on their payer website, it's important to monitor changes to groupers or methodology, or even multiple procedures. They may decide to make a change to how many multiple procedures they're paying with your contract. And so stay on top of that and contact a payer if you see a change that is a material impact to your center. Because of course, in that next section, inadequate reimbursement is a problem for all of us, and it allows the payer, and you may have certain payers in your market who are dominant, and then it leaves providers to need to consolidate to survive. So Pay attention to your contracts and plan to update them regularly with the payers. That is critical. We're seeing, normal kind of fee-for-service diminishing. You may see payers who are doing more value-based contracting or quality programs or bundled payments. So be ready to have those conversations with payers and decide if those types of contracts are right for you. And then moving up to the top right, one of the challenges, we've seen in some markets in the past, there were markets that providers were out of network and didn't contract with payers. And that's really diminishing as more and more payers and employer groups, many employer groups are self-insured and they're very price sensitive. And so they're either limiting access to out-of-network benefits, removing it entirely, and they may limit it by, which is good for ASCs. You may see benefit designs that sort of direct patients to an ASC by changing or limiting the out-of-pocket spend if they go to an ASC versus a hospital, which is great. And you may see more higher deductible plans that then you have to deal with some of that out-of-pocket cost. So lots of things to be mindful of with out-of-network and likely wanting to move in-network. The other thing that we're all dealing with, of course, is the aging population and the growing Medicare population, which just puts more and more emphasis on our commercial contracts and making up that reimbursement with commercial rates to offset the lower Medicare reimbursement. So making sure that you're looking at your whole payer mix and how that reimburses for your facility. And as Matt has talked about, and in the panel discussion, understanding your costs is really critical for your ASC. And if you understand your costs, you can negotiate appropriate rates and understand what cases are appropriate to do in your ASC. You can't make up losses with volume, so it's important to understand what each type of case costs your center to do. We're also seeing payers are working with employers to reduce premiums by limiting access to some higher cost providers. And employees and patients, everybody looks online, checking out costs. That is more prevalent. And one of the ways that employers and payers can work together is to potentially have a narrow network. They may establish a narrow network with certain providers that are lower cost, and an ASC can be part of that. So be open to talking to payers about different networks they have, which would drive volume to your center. I've also seen payers using quality metrics as part of their contracting. So lots of things happening in the payer world, and you always want to pay attention to those smaller payers as well, because those larger payers can eventually purchase a small payer. So let's move on to slide 16. So there are key drivers supporting migration of surgery to ASCs, and this goes along with several of the things Matt was talking about, but we're seeing many more self-insured employer groups and payers, and they're developing those benefit designs and implementing policies to drive surgery to ASCs. And the goal is really to reduce the cost of care and out-of-pocket spend for their members as healthcare costs continue to rise. So as I was mentioning, you may see benefit designs that eliminate copays or coinsurance when surgery is performed in an ASC. So that is really, good news for the ASC, as long as you are set up to do that surgery and it makes sense for your center based on your costs. Again, we're seeing payers doing a better job of educating patients and providing online tools which will direct them to the ASC environment. They may have lower out-of-pocket costs, which is a great thing. And we're also seeing several payers. This has been an interesting development that probably started, or one of the first payers was United Healthcare back in 2015, started with a short list of about 25 codes, where if those services were done in an ASC, prior auth was not required, where if the patient needed to go to an HOPD, the hospital would need to get authorization for those services. It started maybe with some GI services, musculoskeletal, and in February, United added well over 2,000 more codes on the commercial list and about 125 to their Medicare list. And, you know, of course, with anything, there's an exception. There are some exceptions. So if there of course needs to be an ASC in the area for this to apply, a surgeon needs to have privileges at the ASC, and the appropriate equipment needs to be available. So, you know, if it's a total joint and the only surgery center in the area is a GI center or an eye center, then of course that patient could go to the hospital. But we're seeing more and more payers do this. We've seen a couple other large payers, such as Blue Cross Blue Shield of Minnesota, Empire Blue Cross Blue Shield of New York, also set up these types of lists. So this is gaining momentum, and you'll want to keep tabs on this with payers that you're working with. You know, large employer groups are also direct contracting with providers to help mitigate costs. It's all about trying to minimize costs and deal with their healthcare expenses as costs continue to rise. So with that, I will now turn it back to Naya to further discuss some payer consideration questions.
Thank you so much, Amy. So, you know, Amy just ended the note on costs. So I'm going to ask Matt if you could please weigh in a little bit further on what types of opportunities do you see for savings to payers because of migration?
Yeah, I mean, and let's divide that into Medicare and commercial, right? I mean, Medicare, any case from Medicare that goes into an ASC from a health system or an HOPD is a 50% savings for the majority of services. Of course, not every service is paid twice as much in an HOPD setting, and device intensive codes are not as significant, but it's a remarkable savings for Medicare. And as a result, any of the managed Medicare programs that commercial payers are responsible for. So there's a significant benefit for case migration into ASCs at the Medicare level. At the commercial level, I mean, it can be even greater than that. I mean, 2 to 5 times. It just sort of depends on the market, the payer, and the health system that these are coming from. So the savings opportunities are remarkable. And I've been surprised by how many commercial services that are traditional outpatient ASC types of cases are still in health systems. And we're working with a payer client in a market that showed us some of the data that pointed to, you know, they're seeing 75% of the cases that could be done in ASCs are still done in HOPD settings for a whole host of reasons. It's not because of you know, one particular issue, but the short answer now is the savings are remarkable, and you know, I think payers are trying to implement these benefit design changes and other changes to try to access additional savings.
Great, thanks so much, Matt. And so, Amy, just back to you. How are ASCs preparing to optimize their opportunity with payers on migration?
So thank you, Naya. It's really important to plan ahead. Build a business case to talk to the payer. Do your homework. The payer won't do your homework for you. It's, you know, I talk with a lot of folks who think, well, the payer has this data somewhere, but, you know, you're talking with a negotiator who really isn't going to do that homework. So present to them, you know, which surgeons, what is the volume that might move, and be prepared to talk about your costs and what the appropriate rates are for that. And also, just a final comment, payers expect ASCs to be less expensive. That's just a given. So you want to be really armed with, well, how much less expensive are you? And of course, you have to cover your own costs, but expect reasonable rates and have that discussion with the payer.
Thank you so much, Amy. Yeah, and just to keep moving on here I'm looking at the clock, I'm just gonna skip down to maybe one last question for Matt and then turn it over to Kevin. If you could briefly just respond to what is your experience on pricing transparency? And do you think it is resulting with patient demand for ASCs? And then maybe Kevin, you can comment on other actions when we move on to the next section.
Yeah, so Naya, I guess my perspective on pricing transparency is it's still developing, and I say that because I don't know that it's consistently reported yet. It's not necessarily clear to me how the information is being delivered to the consumer. I know there's a requirement now that hospitals report on their costs, and health plans are also supposed to be reporting from their side what it costs to have services in different environments, and that's been delayed a little bit. But I'm not seeing well-informed consumers that are able to assess the various options available to them and then make an informed decision. And as that requirement and technology and capability improves, I think we'll see increased patient demand for ASC services. But at this point, it still feels somewhat inconsistent. My senior age parents aren't necessarily aware of the difference in cost between HOPD and ASC unless I talk to them about it, and I think that's unfortunate. But it is a truth. There's still not a real strong awareness across the consumer side yet.
Perfect. Thank you so much, Matt. Now I'd like to turn over the next section and move on to slide 18 to Kevin, who will discuss key steps to contracting success. And then Kevin, maybe you can talk about the additional ASC factors on payers here. Thank you.
Thanks, Naya. I'll answer that second question towards the end, but let me first start with looking at those, critical steps that will lead to the path to success. And 7 of them have been identified here. And some of these you will have heard through previous comments, either through answers of questions or discussed previously, but I definitely wanted to take some time and focus on these. When you start at the top of the list, you start thinking in terms of case costing. We mentioned that previously, but the summarization of case costs and total costs of new cases being migrated to ASC is critical to understand. And not only for the cost side of it, but it helps to set the foundational needs from a reimbursement perspective when it's time to renegotiate the contracts. And when you're building those cost factors out, make sure you focus on not only the procedure costs, but the fixed costs as far as overhead for the center, and then also build in, margin. Just providing services at cost may not be the best model for a successful surgery center. So make sure you take all of those factors involved into account for the total case costs. And then once you have those costs, think in terms of what are your existing rates. So do an assessment of your existing payer contracts to understand how those contracts would pay for these new services. Matt mentioned it earlier as far as, if your contract's based on percentage of Medicare, or if you have contracts based on, a payer's grouper methodology, do your homework so that you can identify which cases can migrate immediately and which of those that will necessitate renegotiation. And as far as those that would necessitate renegotiation, reach out to your contacts at the health plan and have a conversation with them, and so that they can kind of start that dialogue with respect to driving those cases to the ASC. They may look at their market and identify opportunities, and the health plans, they certainly are open to having the conversation as far as a new service anytime. At least certainly in my experience, even if you have a recent contract that's been renegotiated, excuse me, if you think in terms of a new service being brought to the center, again, the health plans want to, for their own reasons, take advantage of that migration. And then in that arena of rates, I like to use the term holistic rates. So think in terms of holistically, and what I mean by that is across the full spectrum of payers. You have Medicare, you have your commercial plans, and the rates for each of those needs to be taken into account. The idea that commercial plans have to subsidize Medicare, it's real, whether people want to talk about it or not. So you do need to understand kind of the holistic approach to rate identification and the impact that underperforming contracts may have on other rate settings when you're in your negotiations. And speaking of negotiations, the key foundation to any negotiation is data. So do your homework, as Amy mentioned before. Pull your data together, present the data. Don't be shy. Present the data to the health plan. Present implant costs is a good example, or surgeon volumes. Understand what hospitals the cases will be pulled from that are migrating to the surgery center. All of those are key factors that will go into negotiating an effective rate with the health plan. And as Amy mentioned earlier, the health plan may have may have availability to the data, but that doesn't necessarily mean that the contractor is doing your homework for you. So educate them, do your work, do the like I said, the homework ahead of time so that you can have a successful negotiation. And then the last two, I'll touch on those briefly. If you have a ASC that's part of a hospital JV, certainly talk with your hospital partner to have this information available and shareable, but sharing the hospital volume that can migrate to a surgery center to demonstrate savings is very powerful. It's not blinded, it's not estimated, it's not guessed. It could be real information that will help the health plan identify the opportunity and be a successful lever in negotiations. And then last one, we've all experienced the acceleration of case migration that's been a result of COVID-19. So stress to the health plans what the ASCs present from a benefit to the member or the patient as far as a COVID-free environment. That is somewhat taken for granted, but is, I think, a very key piece. So those are the 7 key steps to as far as I deem success in your contract of migrating cases. And then if I could for a second, the question was asked previously, what are the health plans doing? Like what are some factors that actions the health plans are taking? And Amy mentioned United Healthcare very well. Health plans like Blue Cross in Minnesota, Empire Blue Cross in New York, they're following suit. And in my experience, you have this, what I call copycat payer environment, where if one health plan is successful, others will follow. And in doing so, they'll tackle things like benefit design, pre-authorization. I think Matt mentioned that earlier. And last but not least, I think I'd be amiss if I didn't mention that the notion of migration from the health plan perspective is certainly alive and well from hospitals to ASCs, but do think in terms of what it could mean if it was health plans pressing cases to be moved out of the ASC and into the office, and how that would potentially position your surgery center. All right, well, I think that's it for me. I'm going to pass it back to Naya at this point. Some questions.
Thank you so much, Kevin. I'm going to now turn it over to Matt, and wanted to see, Matt, what are your thoughts on the most effective tactics to getting a payer to renegotiate a contract or amend to expand services now that you're looking at migrating the surgery?
Yeah, I think in any contract, whether it's adding a service, renegotiating, the first point obviously is asking, and unfortunately, it's becoming more challenging to get payers to respond. So there's a degree of tenacity that you have to show and a consistency. It's really important if you're considering adding services or renegotiating a contract that you give yourself plenty of runway, plenty of lead time. And oftentimes we have found that with a number of payers, the most effective way to get into their queue, if you will, is to send a letter of non-renewal. Some call that a soft term. It's essentially saying you're not going to continue at the existing rates, and that comes with a proposal attached to it, in my opinion, showing that you want to remain but just want to update. And that's a great time to start to talk about some of these new services and how those new services will save money. I think Kevin and Amy have touched on that already. Showing the value of that savings can often pay for the increases that are being asked for, and it may ultimately be budget neutral for the payer.
Great, thanks so much, Matt. And now when I move on to the next question, I know that the whole panel has had a lot of experience with this, but I'm gonna ask Matt and Amy, and start with Amy. If you could share a story, maybe an example of a strategy when a payer tells you that all the other ASCs in your market, have accepted the rates and they're unwilling to negotiate. What have you done in that case, Amy? Can you share a story?
Yeah, thank you, Naya. Sometimes payers will say that, and they don't really understand that ASCs are all different. One might be a GI center, ophthalmology, or multi-specialty. And so first is just trying to engage with the payer to get them to open up their, mind to actually talking about the rates, because yes, it does happen that other centers have accepted the rates in that area. So it's important. I've had to show the payer that this ASC is different, and what is different about it. What are the unique cases they do? What are the different specialties? How does that compare to the hospital rates? Because in most cases, those cases, if they're not done at the ASC, would go back to the hospital. So show the comparison of, hospital Medicare rates as a benchmark. So really supporting the case, showing cost information to the payer, and as Matt just mentioned, sometimes potentially sending a soft term letter, to push them to negotiate. So yeah, it can be challenging. Thanks, Naya.
Great. Matt, do you have a quick story that you want to add?
Yeah, probably the most recent example is this is the best we can offer, best and final. So that's one of the two great falsehoods that all payers use: the best and final offer, and the other is no one else. Everyone else is taking these rates, etc. To Amy's prior point, it's really interesting when you hear that, and you're the only facility in town delivering a specific service. Let's say a total joint or a spine. So in that environment or in that situation, it's really I found that it was important to disprove that theory with data and show that, well, we understand these are the facilities in town or in the market, and they don't perform spine surgery, and so the only place the surgery is being performed is a health system. And there are some really good public data sources, or when I say public, that can be purchased data sources, Fair Health, Stratasan, and others, and accessing that data has proven to be very useful too. It helps to demonstrate that sometimes the information we receive from a payer isn't necessarily completely accurate, and so there's opportunities in that data to also demonstrate the true value or the true opportunity versus what's being shared.
Thanks, Matt. And now I just want to turn over to Kevin. And Kevin, can you maybe talk about one of the biggest pitfalls and maybe one of the best practices you've seen in a hospital JV ASC contracting situation?
Certainly, Naya, and not, I know in the hospital JV ASC world, some the hospital will perform the contracting and some of the ASC will perform the contracting. And one of the pitfalls I want to address is when the hospital is performing the contracting on behalf of the surgery center, and that pitfall is essentially the assumption that the hospital contractor fully understands the nuances of ASC contracting. Hospital contractors are really good. They understand the hospital world very well, inpatient rates and some of their ancillary services, but they may not have a deep understanding of ASCs. So, make sure you're engaged with your hospital partner to have, to share information, cost information, that is appropriate per legal guidelines, of course, but that will help that hospital contractor be more successful and more mindful of the nuances of ASCs. And as far as best practice, this actually dovetails right off the pitfall, and that's, and this sounds very cliche, but it's communication. So make sure you're communicating with your hospital joint venture partner, be it for cases that can be migrated, be it for contract negotiations. That's where possible, that visual of a unified front is certainly impactful and meaningful. So be sure to communicate with your hospital partner.
Great, thanks so much, Kevin. Amy, I know you've dealt a lot with this in your course of negotiations. If a lot of ASCs will say, okay, the payer already has the claims data. So why does the ASC still need to provide payers with all the details and the data if they've already got the claims data?
Good point, Naya. And really, it's, the negotiator you're working with is focused on just getting their work done, and they won't take the time to go searching for the data. So it's on, the ASC's shoulders to present that data, do the homework, and hand it to the negotiator so they can then review internally with their senior management. So that's really it in a nutshell. Thanks, Naya.
Right. Thank you so much, Amy. And then just in closing on our final panelist questions, I'll start with Kevin, and then Matt, then Amy. Can you just leave the audience with one recommendation you would give to an ASC that is embarking on a new contract negotiation? Kevin, can you start?
Certainly, thanks, Naya. I think the one recommendation I would have, and Amy certainly touched on others, but I would say know your market. Have as much market intel regarding the new cases, where they're coming from, what the to present that opportunity to the health plan when it comes to your contract negotiations, because again, you're in market, they may not be, they may be regionally located, so take advantage of that market intel. That would be my advice.
Great. And Matt, what are your thoughts?
Yeah, I would echo Kevin's with one of the best ways to obtain that information, the information Amy was just talking about, we need to deliver to the payers, is to get started early on collecting EOBs from hospitals, and that's going to require working with your surgeons and their office staff more than likely to request copies. But I've found most patients are willing to share that, especially if it's in the spirit of we want to understand what the costs are, so that as a surgery center owner, I, the physician, want to help save you, the patient, money. And the only way we can do that is understand what the market is. And so that EOB data helps us establish what the rates are currently in the area, and how can we afford to do the services for less, and if so, how much less. And that ultimately helps everybody. It helps the patient, helps the health plan, helps the employer community.
Thank you, Matt. And Amy, do you have a short recommendation here that anybody else has not touched on?
I would just say it's really important to build a positive relationship with the negotiator. Have a foundation, because that person you want them to advocate for you internally. They might be lower level, and they're going to need to take that proposal to their senior management. And so you want to have a good relationship. I know it sounds basic, but I worked on the payer side for many years, a long time ago, and it makes all the difference in the world to have a good relationship and arm the negotiator with the information to argue on your behalf. Thanks, Naya.
Thank you so much. With that being said, we're running short on time, and I'm going to turn it back over to Dan, who'll provide some closing comments.
Thanks, Naya. Okay, everybody, this concludes our program. Please note that if you asked a question we were unable to get to, we will follow up with you after this session. And we hope you all join us for some of our future webinars. And we'd also like to make you aware of ECG's extensive library of thought leadership. So please visit our website at www.ecgmc.com to learn about our upcoming webinars and these relevant and timely topics. I'd like to thank our panel, for a very interesting conversation and sharing their insights. And I, again, like to thank our audience for attending today's presentation. If you have any additional questions or comments, please don't hesitate to contact one of us via the email information provided in the handout. One final reminder, we would greatly appreciate you taking a moment to complete the electronic survey upon exiting the program. And as stated earlier, ECG will make a $5 donation to Doctors Without Borders for each survey submitted. And that concludes things for us today. So thank you, everyone, and have a good day.